Welcome to Cancer Newsline, a podcast series from the University of Texas MD Anderson Cancer Center. Cancer Newsline helps you stay current with the news on cancer research, diagnosis, treatment, and prevention, providing the latest information on reducing your family's cancer risk. I'm your host, Lisa Garvin. Today we'll be talking about a form of leukemia known as acute myelogenous leukemia, or AML. And here to speak on that is Dr. Guillermo Garcia-Manero. He is a professor in the Leukemia Department here at MD Anderson. Welcome, Dr. Manero. Let's first talk about leukemia in itself, because I think we have to distinguish between chronic and acute. So what is acute leukemia?
Okay, so this is an interesting question because even medical students get confused with this concept. So leukemias in general are cancers of the blood or of the bone marrow. And there are multiple types, the same way you have brain tumors, lung cancer, etc. Traditionally, I guess when people were starting to think about these diseases, they realized that there were leukemias that once the patient presented with it, he or she was going to be dead in the next few days, few weeks. That's acute leukemia. And then the physicians saw other group of patients that had abnormal blood cells, but they lived for a little bit longer. Those are chronic. But the reality is that there is significant, so this is a very archaic way of thinking about this disease, but it's the term that we use.
But generally you can say, though, that chronic leukemias progress slowly and acute leukemias come on more aggressively and more quickly. Is that safe to say?
Yeah. So that's exactly right. But then those acute and chronic leukemias are really then divided into different types that originally were based on morphology of these cells, what we call the lineage of these cells that are by and large either from myeloid origin, that is one subset of white cells in the blood, or lymphoid, that is another. So for instance, a neutrophil, that is something that maybe most people will be familiar, is a myeloid type of cell. A lymphocyte is a lymphoid type of cells. Now, these lymphoids can get also raised to lymphomas or to multiple myeloma. So this tree gets more complicated. But you have lymphoid leukemias, you have myeloid leukemias, and then depending on how fast they will get the patient sick or how fast they will develop, then they are called acute and chronic. So then you have acute myelogenous leukemia, chronic myelogenous leukemia, chronic lymphocytic leukemia, acute lymphocytic leukemia. So these are just right there 4 very simple ways to think about these diseases.
And since we're talking about AML, and let's kind of start at the beginning, who is most likely to come down with AML?
All these diseases are diseases of aging. So most patients with AML are older individuals. The same thing for myelodysplastic syndrome. The same thing for CLL, or chronic lymphocytic leukemia. And then acute lymphocytic leukemia is also a disease of aging, but it follows a different peak because this is the disease that is the most frequent type of tumor in children. So there are some specific subset of these patients. But these are the diseases that in general will be associated with aging. Now, not all of them follow the same chronological pattern. So for instance, it is very rare to see a young patient with MDS. I see a couple a year. We see children with AML. So there are different subsets, but by and large, the largest group of patients affected by these disorders will be people older than 60 years of age.
And I think we hear, I've heard the story over and over again with patients I've talked to that acute leukemia can come on like a flu. It comes on pretty quickly. How it manifests itself fairly quickly, does it not?
Yes, and that's actually where the age may make a difference because, for instance, that very abrupt, very acute way of presenting is most commonly observed in the younger group. Whereas the older group, it usually presents more like a myelodysplastic type of presentation where the counts are low.
And what sort of symptoms do we see? Fatigue?
Well, depends on how fast these are. So let's say one of these early patients that you're talking about, younger, the disease is very fast. That person is likely to have fever. that person is likely to have very severe bruising, very severe fatigue. Traditionally, gum infiltration was a way that we will see patients with leukemia where the leukemia goes to the gums, and sometimes the dentist will make this diagnosis. That's for specific types of leukemias, fast growing. So fatigue, malaise, weakness, fever. Many times, unfortunately, patients may present to the hospital already in organ failure because the leukemia cells are in the blood. They tend to infiltrate tissue. So it's not uncommon that you will have liver dysfunction, kidney dysfunction, sometimes heart dysfunction. It can go to brain. So many times when the patients present, they really have multi-system organ failure just because all the organs are affected. But the reality is that right now, most of our patients really present with this kind of like MDS type of picture, particularly the older ones. So they are being diagnosed earlier and earlier. And the symptoms are not so specific. So they may have some bruising, they may have had some infection that triggers this, they may not have felt well over the last few months, but there is not one cardinal feature that you say, oh, I have leukemia.
How often do you, I don't know if I want to ask the staging question, but how often do you catch AML early? I mean, are people like, a lot of people I hear say they have flu-like symptoms, which a lot of people will blow off, quite frankly. So do you tend to get people who are kind of have progressed pretty far before they've come to see a doctor?
Well, so there are two issues here. One, of course, is socioeconomic and educational status of the patient. So some patients may let go their symptoms for longer period of times, and then by the time they come to you, say, well, for how long you've been feeling like this? I said, well, weeks or months. Some other people may have been more aggressive. So this depends. There are other factors. And then the reality is that the disease has very specific molecular features. And so there are no stages per se, but so it's a little bit different from what we were talking earlier in MDS, because this disease, either you have it or you don't have it. But this is also heterogeneous, and there are subsets that behave in different ways. So, for instance, there are type of leukemia called acute pro-myelocytic leukemia, or APL, where the patients have a high tendency to spontaneously bleed. Well, they may have a different presentation than other subsets. So there are different types of leukemia based actually and we know that different cytogenetic and genetic lesions. So the presentation is not so much related to the stage per se, but to the biology of the disease. And that's why scientists have always been interested about this disorder, that is different biologies with very distinct clinical presentations.
How likely is this to be caught? Obviously in a yearly physical exam, they do a complete blood count. Would it be fairly easy to see AML in a typical blood count?
Yeah, because the CBC that shows hemoglobin, platelets, white count will be abnormal. But sometimes actually it's not obvious. So let's say you're a little bit older and you have a little bit of anemia. And then, the doctor say, well, this may be because you are a little bit older.
Yeah, here, take some iron pills, you'll
Something
be fine.
Like that. So it depends. Of course, most doctors are good, and they not only look at the labs, they look at the person and see something else is going on a particular person. But the reality is that it's a question that patients ask all the time. And nowadays, we have people keep their records, they have their labs, and they go back and they say, well, did I have this 6 months ago?
What is the morbidity and mortality on it? Do you just ballpark figures? We don't need exact figures. I mean, in terms of how many diagnosed and how many actually succumb to the disease in a year?
So the overall survival rate of AML in the younger subset. So traditionally, we thought about this disease into patients younger than 60, older than 60. So in patients younger than 60, the overall survival rate, like long-term survival, is around 30%. In the older, this number drops significantly, and prognosis of older AML changes. But now we actually know a lot about how we can actually prognosticate these patients based on kind of simple cytogenetic and molecular features of the disease. So, for instance, chromosomal analysis that is virtually done by everybody right now when we assess these patients has a very significant impact in our capacity to prognosticate these patients. So there are patients that have what we call very complex cytogenetics, particularly if they have an alteration of chromosome 7. They have very poor prognosis with actually most conventional therapies that we have. But then there are patients that have very good features. For instance, if they have something we call core binding factor abnormalities that are sometimes referred to as inversion 16 or translocation 821. These patients actually have survivals that go from 50 to 60, 70%. And then this type of bleeding leukemia I mentioned earlier, this APL or acute promyelocytic leukemia, right now, thanks actually to therapies developed here by the leukemia department, have a survival that is probably between 80 to 90% depending on the risk. So it's not universal. So you cannot say, okay, just because you have AML, you have 30% survival or a 10% survival. You really have to look into, right now, the cytogenetic and molecular features of the disease because, again, there's heterogeneity. There are some group of patients that I feel pretty confident that we can tell them, they have almost 90% cure rate, let's say low-risk acute promyelocytic leukemia. And unfortunately, there are others that it's going to be very hard to actually make them live more than 1 year. The group we are struggling right now are patients that are older. And this is important because these are the most frequent. And patients with bad or poor risk cytogenetics. And then if on top of that, and this actually, they tend to cluster, if you're older with these poor molecular or cytogenetic features, prognosis is very poor. So the spectrum can go from a very young patient with very good molecular features, cure rate could be 80, 90%, to the other end of the spectrum where you have an older person in their 80s, 90s. We see these people here with very poor risk cytogenetics where survival may be dismal, weeks.
We've seen with chronic leukemias that Gleevec was practically a miracle drug. I mean, it did so well and really increased the outlook for a lot of patients. Is there a similar drug for AML that y'all are looking at?
This is a fantastic question because Gleevec works in this group of patients that have this specific alteration called the Philadelphia chromosome BCR-ABL gene. Now, it happens that most patients with CML have this particular alteration. So CML is very homogeneous disease. AML is very heterogeneous. But for instance, there is a subset of patients with AML, that is this acute promyelocytic leukemia patients I referred earlier. They are characterized by a specific translocation, instead of being called Philadelphia.
Which means genes have swapped places.
Well, pieces of chromosomes.
Have swapped.
So instead of being the Philadelphia chromosome or 922, they have an alteration between chromosome 15 and 17. It involves two genes called PML and RAR. It's a fusion gene. Now, in that disease, we don't have a Gleevec, but we know that, for instance, if we treat them with these two drugs called all-trans-retinoic acid and arsenic trioxide, that actually are not chemotherapies, that these are biological agents, we easily can cure 70 to 80% of patients that come to see us, and depending on the risk, even higher than that. So this is another example of how molecular evaluation of these patients may actually lead to really incredible outcomes. What is interesting, actually, is that these patients 15 years ago, they had probably one of the worst prognosis because, as I mentioned earlier, they tended to bleed. And now we know their molecular features. By chance, we found actually that these drugs work, and we can cure over 80% of them without chemotherapy, which is very important because let's say that patient, and we should talk about relapse in leukemia, let's say that person with APL relapses 5-6 years later, I still have all the full chemotherapy armamentarium to control the disease, which is incredible. So this is another example. Now, unfortunately, APL is probably less than 5% of or less of all AML. So it's not that this works for all patients, but for that particular subset, it works.
In a nutshell, where do you see the future of AML treatment going?
The future is very clear, and MD Anderson is putting a very significant effort on this under new leadership, that is genomic data. For instance, we now know that patients with mutation of this gene called FLT3, they have poor prognosis. But we also know that if we use FLT3 inhibitors, that these are drugs that target this particular gene, we can induce remissions. Now, we don't know yet what is the long-term impact of these interventions, but like any other tumor or any other field in oncology, is combining all these different approaches and getting the genomic information so we can start not only prognosticating these patients differently through these genomic and probably even, epigenomic and proteomic, all these basic science data. But that allows us not only to prognosticate, but hopefully to identify new targets. We already have some FLT3 inhibitors, we have MEK inhibitors, etc. But the future actually is into the deep reading of the genomes of these patients, and then the ability actually to take this to the clinic. Because it's okay if in some lab, in some big university, they sequence, but it doesn't help, patient so-and-so that comes to see me tomorrow. Soon, we're going to have that tool. And then I will be able, and my colleagues here and probably around the world, to say, well, this person has this mutation or this constellation of mutations, and this is the best drug or drugs that we can use. And that's the future, is to break it in pieces and try to discover the different CMLs for AML. Probably AML has 15 CMLs, 15 molecular subtypes that one day will have some type of Gleevec, like an APL example. And that will be the way to cure this disease. But it's going to, and these efforts are already ongoing, it's going to require massive genomic annotations of lots of patients.
And this is what we call in layman's terms personalized medicine, because it's personalized to that person's DNA.
Yes, but what the listeners need to understand that is, before we perform that personalization, if this is a word in English, I'm not sure, we need to do the legwork. We need to do the foundation. And the foundation is what we do in places like MD Anderson, is to read these samples so we can then correlate that information with outcomes or with response to therapy, or hypothesize that whatever drug, and some of these drugs, interestingly, they already been used for something else, for some other disease, but for some reason they may target that particular. That's the future. And that's why participation on these clinical trials is fundamental, because you cannot go from, we're going to sequence all these samples to come with treatment strategies. There's an intermediate step that is, of course, the sequencing, but also understanding what this means. And without that step that is done in some type of coordinated, controlled clinical research environment, we will never get there. And MD Anderson is putting massive resources to get this done.
Great. Very enlightening. Thank you. If you have questions about anything you've heard today on Cancer Newsline, contact Ask MD Anderson at 1-877-MDA-6789 or online at www.mdanderson.org/ask. Thank you for listening to this episode of Cancer Newsline. Tune in for the next podcast in our series.